Okay, this video is about how to learn anatomy. It comes from the fact that I've been getting questions from medical students on how should they learn anatomy, what's a good way to do it. Because what happens is in the beginning they get overwhelmed. They're typically told to memorize a bunch of minutia, little detailed things like the muscles in the back. It's kind of ridiculous. And so here's my philosophy of learning anatomy. By the way, I do anatomy for a living. I teach anatomy to doctors with 40 years of experience. Okay, I deal with anatomy, complex anatomy all day long, every day. So I'm very used to it. All right, anyways, there's some obvious stuff everybody should know. You should know the coronary artery atherosclerosis, most common cause of death, okay, causing myocardial infarction. You should know that carotid artery atherosclerosis accumulates right at the bifurcation where the common carotid splits into the external and internal, and right there, and that's a common cause of stroke. And the Japanese who have a lot of hypertension from eating a really high salt diet, they get into cranial atherosclerosis with a lot of strokes, okay? So there's basic important stuff that everybody should know. But the real question is sort of, what's the way you learn anatomy successfully and make it a good experience? And this is a real short talk. We'll go into how to do that on the next slide. Okay, well, first of all, you want to have the best book. The best anatomy atlas is by Frank Netter, MD. He was a surgeon, and he's a genius. It's just the best book, and he's a magnificent artist. He's like the Michelangelo of medical illustration, okay? A next question that comes up is, do you need a cadaver? No, you don't need a cadaver. In my opinion, medical schools should not, and I say this is important, I believe they should not at all use cadavers for teaching anatomy. It is a complete waste of time. And it's a waste of a donated body. Okay, in my freshman year of medical school, there were like 5 of us assigned to one cadaver. I went the first day, and all of us are sort of trying to get a spot at the dissection table, and none of us know anything. There was no supervisor telling us what to do. We were just told to find something, and it was a complete waste of time and a joke. We didn't know what we were doing. We didn't know what we were looking at. You're sitting there inhaling formaldehyde. There's this big room full of all this formaldehyde, and you don't learn anything. It was absolutely stupid. After the first day, I refused to go back. I didn't go back to a single anatomy class. I just went before the lab practical, where you had to find stuff on the body as part of a test. The night before, the instructor had just put tags on where everything was and dissected the body themselves, and they actually really were good and knew what they were doing. The instructor was a professional anatomist. So I just went and looked at all that stuff. And I learned it from just looking at Netter from the book. And that was good. I crushed the test. And so the whole cadaver thing is an absolute waste of time. I wouldn't donate a body to a medical school for that. No, it was, just so you know, it's a complete waste of time. Completely unnecessary. I was great at anatomy. Okay? And the cadaver they didn't learn anything, and it was a big waste of time. All right. Mnemonics, of course, are very helpful. They're a guide to rehearsal when you're learning anatomical reasons, but it's better to understand stuff. Use a mnemonic, fine, but that's good, long-lasting knowledge. To focus on useful clinical things like, coronary arteries, myocardial infarction. That's something that you want to stick with you, because the trend in academics is short-term memorization of minutia. Take a test to see who's the best at memorization, but that doesn't provide lasting knowledge. I've had the medical students coming to me showing me they had to memorize all the muscle in the back, these little tiny muscles. They're completely irrelevant. I ran a spinal injection clinic for years. I never had to know all those muscles, okay? I like the William James concept. He said, what can you do or understand as a result of understanding this, rather than, like I say, the typical way teaching is it's a binge of short-term memory that's all forgotten. It's better to learn the important things well and understand them than to waste time with minutia that you're going to forget, okay? To the extent you can, combine it with the physiology. What's the purpose of the organ system you're learning about? Combine it with the pathology, a couple of the common diseases. Also, some diseases, they're not common, but they're just relevant to express an anatomical point. It's good to look at plain films, CTs, same thing as a CAT scan, computed tomography, MRI, ultrasound when possible, just because those can highlight what really matters. Because in a book, there could be 100 things labeled, but you look at a CAT scan, you'll see there's only 2 things worth knowing. And if you can't see something on imaging and there's no important common disease associated with it, then don't waste time studying that. There's always more information than anyone could learn, so just learn what's worth learning. All right, here's just a simple example. Let's say the anatomy of the genitourinary system, the renal system. Okay, so here's the kidney, here's the ureter, where the urine passes from the kidney down to the urinary bladder. And so that's the simplest thing anybody should know. But I'll just show you a little bit more detail how I would teach anatomy if I taught anatomy to younger persons. Okay, I teach anatomy to physicians, not to, and the residents a little bit, not to medical students typically. Okay, so let's say this is the most common spot. You get a kidney stone that's symptomatic, sitting in the ureteral pelvic junction because there's a transition in diameter from the renal pelvis to the ureter. So you look at the stone here, what are you going to do with it? If they can come from below, a urologist will put a scope up and they can maybe basket it out. If they can't basket it out, you know, an interventional radiologist, like what I used to do, would just come in, put a nephrostomy tube, a drainage tube through here, and then they can take the stone out through that manner. Why do you, this will take 30 seconds. I'm just showing you how you think about anatomy. Distal ureter, common spot to get obstructed by enlarged lymph nodes from cancer. Stones often lodge at the junction of the ureter with the urinary bladder. That's called UO, ureteral orifice. UVJ is ureteral vesicle junction. Bladder is also called the vesicle. Cancer will sometimes grow up and cover this. Usually with a stone, the urologist can come up to the urethra and get across this stone and put a stent in there and then get the stent out. With a bladder cancer, a lot of times they can't find the ureteral orifice, and an interventional radiologist will come from above, put a drainage tube. Okay, the fornix is where kidney stones will tend to, it's a spot where the pressure is the highest. They'll pop and you'll start leaking urine into the abdomen. You want to go into a calyx to put a drainage tube because if you come into the central pelvis, the blood vessels are too big, the patient's going to bleed. So anyways, that's how one thinks about anatomy. It's not, can I memorize 20 little muscles in the back and then forget them after the test? Real anatomical thinking is, what's going on here? What's the pathological problem? What can we do to help this patient? That's useful to know, and it's memorable.